Good afternoon, everybody. My name's Leanne Wells. I'm the Chief Executive Officer at the Consumers Health Forum of Australia. I'd like to welcome you to this first of two webinars we'll be doing over the course of this month and November to focus on the issues of privacy and patient consent raised by the Australian Institute of Health and Welfare's planned National Primary Healthcare Data Asset. Our next webinar on November 11 will explore the benefits of the data asset. So for now, we are looking at privacy, consent and protection for consumers. Just by way of opening remarks, I think it's important to remind ourselves about what the community thinks about data. There was a recent report released by Research Australia. It was a consumer sentiment survey, and it was clear from that the majority of Australians are very supportive of the collection and analysis of de-identified patient data when that's used for the public good, when it's used for good policy, good research, shaping better services for people. And that was certainly a theme that came through in the consultations that the AIHW have done as well. But what's also clear, and that's our topic for today, that we do need to take into account, and we need to take into very careful account the challenges of ensuring that privacy and patient protection, that all reasonable steps are being taken to do that, and that all reasonable steps and best practice steps are being taken to ensure that patients are giving consent to the use of their information. So we've got a panel of experts here with me today that I'll introduce now. We've got next to me, we've got Michael Frost, who heads AIHW's Primary Healthcare Group, and he's responsible for the development of the Primary Healthcare Data Asset. We've got Pip Brennan, Executive Director, Health Consumers WA. We have Dr. Jan Radford, a GP and Associate Professor of General Practice at the University of Tasmania. Karen Booth, President of the Australian Primary Healthcare Nurses Association. And also down the end there, we have Adam, who is a member and representative of Health Consumers New South Wales and a consumer advisor to the Clinical Excellence Commission here in New South Wales. So a very broad cross-section of experts, and hopefully we can have a very good, vibrant discussion about issues of privacy protection and consent today. But first, I might just ask Michael, if I could, Michael, for you to just briefly describe the primary healthcare data asset. What is it that we're actually talking about here?
Thank you, Leanne. Well, I guess the broadest aim of the data asset is to support a better understanding of what happens to patients in the primary healthcare sector. So primary healthcare at $63.4 billion in 2017-18 is the second largest sector by expenditure of the healthcare system after hospitals. But also it's very important as that first line of the healthcare system that people will experience. And so what happens there will define a lot of their experience of the healthcare system. So primary healthcare is very important, but despite that level of importance, we have some key data gaps there about what happens to people in that sector. We have some sources of data about what happens in the primary healthcare sector through Medicare benefit schedule information, PBS information, some surveys and specific collections, but what they don't tell us is some things about, for example, why a person goes to see a primary care practitioner, and not just general practice, but could be nursing, optometry, dentistry, allied health, Aboriginal healthcare workers. There's a range of different parts of that sector, why they go and see them, what happens when they do, what are their diagnoses, what are the courses of actions that are proposed, and what happens if those actions are taken by way of outcomes and the patient experience. Those are gaps that we're trying to fill using this data asset, and the aim to do that is, like we do with our other collections, is to inform the public and health consumers generally about the primary healthcare sector, to support clinicians and healthcare service providers in improving their services, improving experience, improving outcomes, to support better health system management, planning and policy in the healthcare system, as well as supporting research on primary healthcare that can, again, support all of those things I've mentioned previously about consumers and clinicians and health service providers. So In terms of the operations of the data asset, that's still something that's in formation. We're early in this process. We're looking to engage with people about how that should work. We're aiming to engage with people about what are the advisory and directional decision-making arrangements we need to put in place, governance. What are uses that are good uses for the data asset? What are uses, I guess, the corollary of that being those that are not good uses for the data asset? Those kinds of questions. We have been through a process that you referred to in your introductory comments, running consultation workshops around the country and a submissions process. So we have some input on some of those things, but we're going through other processes now. As key themes that came up there were that we needed to continue throughout the process to engage consumers, to engage the sector, engage particularly the Indigenous sector as well, about all of those questions. And so that's where we are now, and that's what today is about for us.
Thank you, Michael. And Pip, you've been a long-standing consumer advocate. Obviously, primary healthcare is a setting where people go for a lot of their care, but it's also a setting where we're dealing with lots of very personal and intimate information about people often. So from your perspective as a consumer advocate, what are the important issues as you see them when it comes to privacy and patient consent?
Thanks, Leanne. Look, I think I just would like to begin by acknowledging the Aboriginal and Torres Strait Islander people as the traditional owners of our amazing country that we live in, and it brings me to mind of thinking about the issue of Aboriginal and Torres Strait Islander data sovereignty, and that concept where it's actually not just about individual privacy concerns but a community privacy concern. And I think that's a really important area for us to sort of keep in mind. But I think some of the other things that you talked about that survey, I think that people expect that we are already using this data and we already know what works. So I think there is a huge interest amongst the community that the data that we have, that we gather the right sort of data to work out, is what we're doing turning the curve. But I think, consumers understand that data is the new oil. And so we all understand now that we have to be perhaps a bit more cautious than we have been. I think the My Health record, we now have 90% of Australians have a My Health record. But before that process started, we thought it might be 99. So we sort of lost about 9%. And a lot of that stuff, I think, there's that increasing concern about what's going to happen. There's a data breach almost every week. There's real concerns. And I think too, there's that. I had some really interesting conversations around, so in West Australia, we're finally going to catch up with the rest of the nation. We're looking at doing privacy and data sharing legislation at a state level. Most other jurisdictions did that in the 80s. So if you look at that 1980s legislation, you look at our world now, there's a kind of a little bit of a mismatch. We had a look at, what they've done in Europe, the General Data Protection Regulation process, but that sits within a frame of civil rights we don't really have in Australia. So I think there's some really kind of key questions about our rights. I think too that thing of where, click to accept, we do that all the time. The Norway Consumer Council, for example, they worked out that you could read the New Testament by the time it took you to read all the terms and conditions of, say, 33 apps that we all use on our phones. And so what we're doing is, we are clicking away at a range of rights, including, things like, there's a really interesting website called Terms of Service Didn't Read, and I think people might want to have a look at it because it almost does like a health check of different websites around things like, it may collect, use and share your data, it may read your private messages, you sort of sign away all your rights if anything goes wrong. So I think, we understand on the one hand that, if it's free, we're for sale and our data's for sale.
But there's a user beware message in there, isn't there?
That's right. And that's also, I know that's a bit of a different approach, but as I say, the public do want us to be using our data for good. And I think, again, with the My Health record, I think the third-party apps is contentious. I think, using something like Health Engine rather than a government app makes people feel a bit nervous. I think the Australian Institute of Health and Welfare, on the other hand, has a really great reputation amongst the public because it's not for profit.
So, Jan, can I perhaps ask you then, given Pip's comments there about the things that consumers need to be aware of around privacy and consent, what role do you think the GP should play as the primary carer, I guess, in the primary care space in explaining privacy and consent issues about this data set in particular?
I think it's rather difficult for them to start explaining about AIHW's primary care data set because it isn't a thing yet. And they're part of the conversation. So Michael and his group have had workshops around Australia, and my understanding is general practice representative bodies have had representatives at all of those workshops. Everyone's keenly interested in this whole thing. And I think generally can see benefit, but then are very wary because as a researcher, I have worked with practices in the research space now for a while, and they're very, very aware of their data custodial role. And so they know very well, I mean, it's a general medical training ethic, that what the patient and the doctor talk about is confidential. And if we go back to when I was a girl, when we wrote this thing on paper, the notes, those notes were kept as an aid memoir by the doctor. Legally, I understand in Australia, the GP or the healthcare practitioner who generates the notes and therefore the data owns, or the practice that employs them owns the data, but that's not the social licence, that's just the legalities. Yeah. But they're very, very, and I have not yet come across a practitioner or practice that is blasé about that role. So when it comes to sharing data, de-identified data, for example, which is what Michael and his group want to gather, they will listen intently to a proposal that is about good, and they have to have a lot of trust in the person or the groups, I should say, who are going to carefully take data and warehouse it and use it for the greater good. So it's a big, long journey of building trust because they don't want their trust that the patient might have in their doctor and their practice to be compromised. Yeah. So I think that what they should say is really hard to know yet. With my health record, so I'm a clinician as well as a researcher, I always have conversation with my patient who might have my health record, and you say, well, what do you think? Would you like to do this? And I will absolutely encourage it for someone with complicated issues because and try and update that record as often as possible. The contemporaneous nature or not of that record always bothers me. But it will get better over time. So I think I like to always have the consent, if it's and that's an identifiable data source because you've got your name and everything on that. If it's de-identified, well, you know, within the practice we audit, and the only way we can generate an up-to-date diabetes register, for example, is to try and find all our diabetics. And we haven't had any complaint by anyone saying, "Oh, you found me," and how come, you know, your practice nurse colleague is ringing me up and wanting to know if I'd like to come in for a checkup when I have not yet had that sort of pushback. So I think within a practice, people are quite happy that we're being careful within the practice, but going to the outside the practice is.
And do you think that's a universal approach and practice across general practice?
Look, I think it is. I have heard stories.
Jan.
I've heard stories of people being willing to, you know, give their data away and selling it, say to a drug company or to somebody else. But I have not necessarily known those, and that's an anecdote. Generally speaking, people take their legal requirement really, really seriously.
And your point too, with the primary healthcare data asset that's under development here, the trust and social licence is as important because medicine is the relationship between the patient and the provider. It's as important to the provider as it is to the patient.
And I think there's quite a bit of confusion about just what data's going to come out. So, you know, is it going to be all my detailed notes, which, you know, I do a lot of mental health care, and so I have to, I describe exactly the situation the person's telling me so I can remember and go back and we can review. The patient can see what I'm writing, it's on a big screen, versus that I might put that they've got a major depressive disorder, which is just a label, and it's not detailing all the details of that sort of thing. Anyway, I might be talking too much.
No, you're fine. And Karen, from your perspective, and we'll come to Adam in a moment too, because there's lots of consumer issues with this. Karen, from your perspective, representing primary care nurses and working as a primary care nurse yourself, what are the issues that you think are important?
I feel as though I've been coding data non-stop for at least 20 years and encouraging others to do that so that we can actually get a big picture of what is happening in our practice, but also to help the big picture in the community. And I think what we really need is a big picture view, not only of the state of health, but also the pattern of disease burden in our community. And then once we have that, then we're able to more accurately match the health service and care needs of the community, and to better understand what services need to be developed and what needs to be better resourced to deliver care that the community actually wants and needs, as opposed to, we think they will need this. So we actually have a better idea of what they do actually want and need. And I think building that big picture needs really good quality data collection. It needs analysis, but it also needs consumer confidence. And I'd like people to think that the data that they give is a gift to the nation that actually helps to build that big picture, to design needs in practices like we do, to design needs for your local community, but also at a state and national level. And just building on to the previous comments, nurses help to collect data in their practices every day. They interrogate that data. They work out health promotion, who needs screening for risk, calling patients in for diabetes assessments. So we're already using very sophisticated way the data that we collect from patients. And again, data that we collect to call people for preventative health checks, or data that is collected to big picture is de-identified. Your personal details don't go outside the practice without your permission. That's very, very important to know. And I think the other thing about good quality data and sharing your information is it helps to identify areas for quality improvement, and for health professionals, it helps them to identify risks, and consumers, again, as I said, need to think about how they contribute to the big picture for health planning.
Thanks, Karen. So I think what you're reinforcing there is a very strong theme that came through all the lead-up consultations to this, that there's an absolute business case, if I can use that term, for primary healthcare data to be used to good effect, to good public interest, whether it's at the national level shaping policy, whether it's at the practice level to quality improve services. Just coming back though to the issues and the sensitivities around social licence, because on the one hand, I think we know from the research, we know from the consultations that people are generally accepting of their data being used for that when it's de-identified, and more accepting when it becomes very evident to them as a patient in a practice, or as a consumer advocate sitting on a steering group, as a patient advocate, as Adam is, advising primary health networks on needs analysis and things like that. But I think the issue of privacy, consent is an area where we really do need to strike a balance, and I think we're dealing with a post My Health Record environment where, as Pip said, there was quite a fine point put on community concern around that. So if I could go to you, Adam, as a consumer advocate as well, what do you believe open and transparent development of a national primary healthcare data asset? Not so much, remember that we're talking about not necessarily, it's linked, data being collected and de-identified and used at the practice level. That's one source of data that will come into this national primary healthcare data asset. But from your perspective, what would open and transparent development of that data asset look like?
Well, open and transparent, they're really two separate things, and they are a double-edged sword, because on the one hand, we're talking about privacy, but on the other hand, we want things to be open and transparent. So I think we have to recognise that there's a tension there. And I actually think before we even get to that particular question, we have to better define what this asset is and what the business case is not necessarily to the practice, but to the patient and their family. Because as I sit on committees and interact with the people at the state and sometimes federal and local level, they are overwhelmed with data from sources that are already existing. So I think the first open and transparent question this data set has to answer is, what hole are they filling? Because as I go around, I see plenty of people with plenty of data already. Even in the primary health sector, where you can pull the census data, other council data, sometimes the state level data, again, which is already there. So the question really is, what is the specific new data that is needed? Why is it needed? And what ultimately will be the clinical and social benefit?
So, Michael, perhaps could you respond to that? Because that's co-design approach is coming to working with interests in the data asset to define that scope. What is it? What's its scope? What's its purpose? So you touched on some of that when you made your opening remarks, but maybe a response to Adam's comments there.
Thank you. And I think it's true that there is quite an overwhelming amount of data out there already about a number of different things. But many of the sources still for us in terms of things that could contribute to better information for consumers, for clinicians, health service providers and researchers, as well as policy and planning, is that the information is still about the population at large and not about their passage through the actual primary care sector. The amount of information that we have about why they're there, what happens to them when they're there, what they think of what happens to them when they're there, is much less than we have on, for example, the same people going through the hospital system. That's had a long time now of developing national data sets that can inform all of those processes. So I agree, there are a lot of sources where we do know some things already that about population health and about the need in the population and about some outcomes as well. And there are surveys that can get at patient experience, but there aren't a lot of sources yet readily available that can provide that level of information to inform all those audiences about the actual day-to-day business of the sector itself, not just general practice, but other parts of the primary care sector as well. And those things can inform, if you understand why someone's there and how their pattern of care flowed from that point, you can understand a lot more about what you can do to improve that than just understanding the general level of need in the community.
I guess for me too, the opportunity around open and transparency, this is really talking about how all the different universities and government agencies and hospitals and health services can have the data, but why can't consumers have that data? Why can't we be making more informed choices? Really, at the moment, most of our health choices are made in fairly largely a vacuum of information. So there's a lot of things out there that we need to be able to routinely access. And I think, there's fantastic opportunities around being partners in our own care. And in order to be partners in our own care, we need to be informed. I think to that idea about, what should this be? What should the business case be? In our dream world of co-design, that would be like a 50-50 split between, consumers and other stakeholders, and a real sharing of the problem and a real coming up with a solution together. People talk about co-design a lot, but they don't usually do it. What it is consultation. Nothing wrong with consultation, but a lot of consultation exercises are dressed up as co-design. But co-design is something that that takes time and, will change. Usually we'll end up changing things slightly because it can change the thinking from the beginning when you're working with the people that you're hoping are actually going to benefit. So I think, rather than thinking this feels a bit like this is what we're going to do to consumers, how about doing it with us?
And we are hoping to work with consumers through this process. We are still at a very early stage, and we're particularly keen to understand exactly what information that consumers are seeking. We can, as a data organisation, we can abstract that and think of what we think consumers might want about the system, and we produce a lot of information in our high-level reports that does that, but we're keen to understand what information people want to see to put their treatment in context and to understand what they're doing when they go into the system.
And I think just to add to that, based on what I know of the tertiary health system, I've had studies done in my health service about people coming into emergency. What do they want? What are they concerned about? At number 10 will be the thing that's actually wrong with them. The things above that will be, can I park my car here without getting a fine? Who's going to feed the cat? Who's going to take care of the kids? So a lot of the feedback you will probably get from consumers will not have anything to do with their health at all. It will be a range of external, family, personal, professional issues that are impacted when they have to go through a health crisis.
And that's an interesting point, isn't it, Adam? Because back to Michael's point about at the moment we've got a primary healthcare set of primary healthcare data where we can see, you know, from MBS items claimed, you know, what service utilisation is looking like. But that, and likewise, you know, PBS, we can see what sort of scripts are being written and filled for what. But it doesn't really drill down into that next level of the patient journey, the life course journey, the experience of care, the bundle of services that people are getting or not, and the social determinants of health, and the need to bring that into consideration for how we bring some of those measures or indicators or data sets into this primary healthcare data asset over time. There seemed to be quite a lot of support for that in the consultations as well.
Yeah, and I think there is an assumption that the data will show what more health services we need, but it might not be health services. It might be coaching. It might be peer-related services. So it needs to be that whole mix, that whole of human experience.
Can I just make a point? Having generated medical records now for 34 years, sorry guys, I can tell you what we do tend to collect, and it is very limited. I totally agree with you. The wider view of health is just, you know, it's designed as an aid memoir. It's becoming this thing to share. It's going to evolve, and I think having consumers have input into their own record, of course, will happen over time, but it's a journey. So, but there are some really basic things like 85% of people in Australia go to a GP once a year, at least, you know, and lots go very much more. So you have the opportunity just to ask, are you smoking or not? Height and weight, blood pressure. There are some very basic, really key numbers that can have paint a picture of a population's health. Who's not coming? That's important. There are some people who are totally unable to access what we consider to be a gatekeeping service, which is general practice. General practitioners and their colleagues, the general practice professional workforce, want to serve their community. They want everyone to be able to come. They would love to be able to bulk bill everyone, I can tell you that. They can't always, unfortunately. But they want to be available and to offer that continuity of care. I've done some research using, Michael talked about some data sets already existing, and so there is one through the NPS, and that they spent a long time gathering trust to have GPs and practices willing to share their data de-identified. We've done work on kidney disease, so we can actually...
Can I ask you there, Jan? I mean, I think the consumers at the table and the consumers listening in too, yeah. I mean, that is an example of a data set. How's consent, you know, the idea of, you know, really fit for purpose consent managed with that program?
Well, here I'm sort of declaring that I'm on the data governance committee now since last year with the NPS, and I'm very impressed with our consumer reps on that body, and the general good ruler is put across every request for data and rigorously enforced, I would say. I could be really very well, you know, biased. I was involved in getting our practices in Tasmania enrolled. It took time to go and explain what was likely to be a benefit. It was a new thing to do. The practice gets a benefit back because their data is pulled together and pictures of their population of patients is taken back, and it might be around using better medication management, say of chronic nerve pain. It might be about better care for people with hepatitis C. It might be about stroke prevention. So the data is then shared back to the practice to help them improve their quality of care. The NPS never knows who the individual patient is in
patient
data.
sitting in front of you, are you explicit about
The fact that we have a poster on the wall, and I know since then they've said, oh, that's not good enough, but we have a poster on the wall saying that the practice is part of this and you can withdraw and your consent to be part of it and your data will not be collected.
Right.
So there is a means to not be part of that, and that should be the case.
But that is an opt-out
Adam,
situation, not an opt-in.
That's true, and it's de-identified. So legally and ethically, if you go to the NHMRC ethics committees, all of the work's been put through all of those sorts of filters. So it's as good as we could do at the time, and I assume it's a conversation to go on with Adam. It's not like it's going to be, entombed in stone.
I'll come back to Adam in a moment. I just want to remind our people listening in today, if you do have a question, we're taking questions. I'll come back to Adam for a comment on those issues in a moment. So please log your questions. I'm starting to see them here on the screen here. So we'll get a comment from Adam on that, and then we'll start to go to our listeners for some questions and commentary that our panel can respond to. So Adam, just thinking again about the national primary healthcare data set and the way it's been described conceptually to us by Michael, what do you think are the top three privacy, consent, consumer protection considerations that you would expect and want AIHW to be thinking about?
Well, I think the consent actually has to be very active and very explicit. And I give the example of I'm quite happy to be involved in clinical trials, but when that happens, they send you a lot of data, they give you a telephone number, they send you through forms. So you are very clear on exactly what you are doing. It is made very explicit where the information will be held and what it will be used for and how long it will be used for. The difficulty with national or international data sets is that they are that far removed, you don't know how long they're going to be held, and you don't know for what third-party uses they might be used. And I think that would be a big concern with many consumers. Also, the second issue would be really what's the danger and what is the response in misuse, because we have plenty of examples. I just have to use the name Cambridge Analytica, and there's a whole very public mess there about how did data get out, what was it used for, and how detailed was it? And the answer there was it was particularly detailed. And I think that particularly frightened a lot of people because we realised we are really tied into an electronic and a data-dependent world, but we've sort of sleepwalked into this scenario where now to have good quality healthcare and the data to back that up, we are sort of in a situation where you can't say no even if you wanted to. So I think there is also the feeling of, do I really have the capacity to say no, or in the end, will it be yes anyway?
So on the one hand, we've got general public acceptance that data for good is a good thing, but we can't be careful enough given the wider world of data and how busy and exponentially that's getting more complicated and growing. AIHW, I think it would be fair to say, absolutely, and most would agree, has a very good reputation as our national health and social care data, welfare data custodian, analyser, disseminator. Just a comment from you, Michael, about, a response from you, I guess, about Adam's comments about we can't be too careful. What steps will AIHW be taking, and what will you be keeping top of mind to protect and inform consumers as this primary healthcare data asset continues to develop and ultimately get implemented?
So I think the kind of steps that we would take and what we would have in mind is to take what a number of people have said, including Adam today, about people generally want to see these kind of data used to improve health services and to improve care for patients and to improve what patients know about the system. They want to see that, but they want to see it used for public benefit and for public good. That's something that is built into, I guess, for want of a better term, the DNA of the AIHW. It is in our Act that we're to serve the health and welfare of Australians by providing robust, reliable and regular health information and statistics. And then we have, in addition to that guiding principle of the good, we have a number of protections. Obviously, we comply with the privacy principles and the Privacy Act as we're required to. We also work within the confines of our Act and meet additional obligations there, including particular confidentiality obligations that require us to ensure that the data is used for set purposes only and is not used in a way that is identifiable unless there are certain exceptions that apply to that. Those purposes then are where we would define something like these are the acceptable uses for the data set, and then we would have binding conditions then from data providers to adhere to that. Then all of that, of course, has the additional protection of an independent ethics committee that we have, and that must oversee the formation of any new collections, any changes to those collections, and the uses of those collections. So again, we have a number of protections in place to say that we will work for the public benefit. We'll work in terms of the conditions upon which we have the data and won't go beyond that. That's a protection against, for example, the Cambridge Analytica type thing. And we are also, as you know, a not-for-profit independent statutory agency of the government. So we're not going to be on-selling the data. The data will be used for the public benefits and for the purposes for which we have the approval to use it from data providers.
So with a new data set like this, well, it's not so much a new data set, there may be new elements of data coming into the primary healthcare data asset over time, but in the first instance it's going to more efficiently and effectively pull together existing primary care data and bundle it up and present it and analyse in ways that we haven't seen done before. With that in mind, it's new, it'll have a value proposition, we hope, to the community and to clinicians and policymakers. We've got the AIHW with all those requirements on you to protect consumers and act in the public interest. Do you think, Adam, Pip, anyone who wants to comment to this question, that there's a need for a community education program about the data asset in particular, but perhaps about, you know, the way consumer health information is used these days,
I think
just to create a community narrative around it against the backdrop of how privacy and protection should be managed?
I personally think yes,
I'd like to
yes.
Given the amount of trepidation around the My Health record, and we had there was quite good campaigns around the type of security that would be built around it, but the media that came before that and quite a lot of sort of concerns, not necessarily legitimate concerns, some of them, around how that would be managed, then made it much more difficult when the My Health record was introduced. And I think to have an education campaign, not just for consumers, but also for health professionals around the type of data to be collected, the safety of the data, and explaining to consumers how that would be used, would be much better started early than actually when we're ready to go for this, so that people are now used to the My Health record. I rarely have anyone complain that they wouldn't like something uploaded. I always ask before I upload any information. And I think that's good because health practitioners are now in the mode of doing that, so that when we move to collecting data and permission for the data asset, there's already a behaviour established, but we really need a good communication program around the benefits, but also about protections for the consumer. And I also think that we'll need to engage a bit more with the software providers about how you manage opt-out.
I would want to think around the idea of educating consumers. Look, I think number one, I would go back to the concept of co-designing the messages, and I think you need to think about that proper segmenting of the market. So health nerds like myself will need a certain type. Other people who are kind of la around health, they will want something else. But what you need is you really need to think about that social marketing principle where you're using marketing for good. And so you are actually co-designing those messages with those different segments and, doing a range of different things, not just one. So, we are quite ignorant to
I agree. We do need this conversation and it needs to go on and on and on.
Exactly.
And,
Iterative, yes.
Very much. And I think we have to look at issues of language and literacy, and so it has to be pictorial. I would submit stories are going to be useful and powerful. And I think, I understand, for example, that the Australian Bureau of Statistics is working with Aboriginal groups with community to work out how to reach community members. And so they're leading the way. Ask them how it's done. And again,
Share the problem.
Share the problem because, and there'll be other communities who English is a second language, of course.
Or fifth language.
Sorry?
English can be a fifth language in some communities.
Absolutely. Yeah. So we really need to reach everybody. For example, I'm just off the top of my head thinking of cervical testing rates. Very low amongst groups who literally don't understand, they don't get the message that this could be a life-saving procedure to have with a healthcare practitioner. That's a failure. That's a failure of communication. But we need those stats too, who isn't coming and why and how then can we work with community to make that easier, and that's sort of happening at the moment in that area.
Yeah.
But,
so that's, thanks, Jan.
Very much a yes.
Yeah. So that's a resounding message to government and the AIHW that if we are to create and sustain a social licence and a confidence in this national primary healthcare data asset, yes, legislation, regulation is important, as is community education and messaging.
Equally, I think, Leanne, the thing we face is the name. What is a data asset? I mean, that will start off the greatest fear campaign because it is data. So I desperately think it needs a rebadging, a new name, and it needs to be focused on answering the question of what is in it for you, why should you use it, and answering simple questions like that. And if simple the why, what, and how will you benefit cannot be answered in 30 seconds, it won't work.
Very sage advice, Adam. Thank you.
Extremely.
Just to our listeners, please, we are open for questions. I've got a comment and a question here from Paul, and it takes us back to the issue of the importance of capturing information and using it for public good about patients' experiences. And his comment is, so Jan and Karen might want to comment on this or shed some light on this for us. If you want to get an idea of how patients feel about their care, why not use something like the assessment of care tool discussed, and it's in a national journal of medicine. I've got a link here, I can't actually refer you, but I think the general point is about the longer term benefits of PREMs and PROMs and measures of patient activation. How are they going to be?
Could you unpack all those abbreviations, Leanne, because I think they're wonderful, and I know New South Wales is doing some fantastic work in this area, the New South Wales state government. I've met with them at conferences and they've been on it for like 10 years. So the ability to attach that information to the record to be then used by us when we see people would be brilliant. PREMs and PROMs, can you patient reported outcome measures and we should have explained those acronyms. Patient reported outcome measures, patient reported experience measures, for which there are validated tools. And we have a bit better technology now, so maybe people can go on at home and fill in these tools online. I know my mum, who's 83, is now iPad literate after 2 years. This is pretty amazing. And so she could go on maybe and give some feedback.
That's part of the longer term aspiration, isn't it, Michael, that to the extent that we've got the means of capturing that information and doing it safely and de-identifying that as well,
Yep.
that over time
That it could get then attached to your record.
we could bring that into the asset.
And that could
Yeah.
that could be. So the benefits of that, if it does occur, and partly we're dependent on, I guess, technological developments and
Yeah.
the use of these tools in the sector. So part of the timing and where we've come at with the data asset, and I apologise for the name, I must say, but we'll work on the name.
Data for good.
Data for good.
Is that, you know, we are at a time now where the record systems make it possible for this kind of aggregation of data. So the same would need to be the case with the patient-reported experience measures and outcome measures. If they do become available, then they could be part of this. And the strength of that would be that you add that then to, you know, if we know what people who have diabetes look like when they're going to the doctor, what do they talk about, what do they want to do, we can also then know afterwards how did that go for them. And that would be really powerful. But again, it's dependent for us in terms of where the data sources go.
Yeah.
We do know some practices are using that.
Yes, yes.
Some people are using that tool. And whether or not they're capturing that as part of their record is another question.
Yeah.
But in time, I imagine it would be.
Yeah. Karen.
And look, I would add, having that information would then, looking at the patient experience, we could say, well, how could we make it better and what do we need to change? Was that referral appropriate? Do we need a different type of care activity for this patient? So it actually helps to build a better sort of picture for a particular patient. But it also, if you've got enough data that you can get trends from that, you can actually know, do you actually need a different health service or a different actually type of health professional providing a particular service to improve that person's experience.
I would just like to pick up, because interesting, when you started that, you talked about PROMs and PREMs and you slipped in PAM as well, the patient activation measure.
Yeah.
So again, as a consumer advocate, I would suggest that the evidence is not 100% clear around what the reported outcome measures and reported experience measures might do in terms of changing safety and quality in the same way that the patient activation measure might. And I guess I would like to also highlight that we do have the patient opinion website across our nation, although it hasn't been uptaken everywhere. But that's a slightly different way of tackling the same thing in that somebody right now in the public can just jump on and provide their story of care. I know it hasn't been uptaken by primary care yet, but as it morphs into a health and human services platform, as it will in 2020, I think that will come. As it has, you know, it's been 15 years in the UK, and it really is part of that continuous improvement conversation that's held, you know, with the public and the service in a transparent way. And so I guess I'd be really interested too to have a look at the concept of the patient activation, of that connection between good health outcomes and how activated a patient feels about their care.
I think I think that's a whole. Look, I think it's important
Another
issue
huge
to raise.
area.
Kip.
Yeah.
It's a big issue that we need to have a conversation about. I guess my comment would be with something like patient opinion. It's opinion. It's qualitative. And this is about a data asset. You know, I think that to you, Michael, you're the data expert. How, if at all, would the primary healthcare data asset over time, and could it even have the capacity to somehow bring in capture of data that's more qualitative in nature than quantitative?
Well, I mean, that is a challenge, and sometimes it's found in then surveys or tools that can capture the information from the patients. That's qualitative in that sense, but it would still need to be categorised by the questions.
Exactly.
In time, there are technological developments that allow us, or we imagine will allow us in time to more systematically look at what's called unstructured data, things like natural language processing, AI, machine learning, that can extract information that's not in a systematised form. Which is what most of the data that we require is. But they would need to be developed over time, and people need to build confidence in that that it's answering questions that we want answered, but also that it's answering them well. But I think there is the prospect in time that those tools will become available to us and that we could use them.
We shouldn't let go of that aspiration.
But one challenge that will lie under that, though, will be that we do like, by and large, to produce and work with de-identified information.
Exactly.
And so unstructured information could hold within it identifiers, and that would be the key first step for us as an organisation is how
which opens up a whole different conversation on the privacy, consent, consumer protection front.
Equally, what it does if you're dragging in different surveys or mass data sets, I think there's a legal question over under what circumstances did the people who gave into those other data sets actually consent to, and does that survive the amalgamation of the prior data sets into a new format? So I think some care has to be taken about covering clauses and maybe even having to check back with people about reconsenting to a new function that wasn't anticipated, and working out just how cumbersome and time-consuming and potentially expensive that could be.
Can I just ask a question? We've touched on My Health Record and the issues of privacy and protection and that journey, which is still very fresh from a consumer protection, privacy protection perspective in many people's minds. This may well be a point of clarification, I think, that we're going to have continually reinforced as the National Primary Healthcare Data Asset develops. And the question is, what will the relationship, or what could the relationship between the National Primary Healthcare Data Asset and My Health Record have, given My Health Record is a sort of a personalised drop box of people's personal health information?
That's a really good question. And I mean, I think that My Health Record can in time answer some of the questions that we're looking, and that's where we need to be looking with the primary healthcare data asset about what gaps do we fill.
Yeah.
This is additional information that might be richer information that's in, for example, general practice clinical information systems, than is then uploaded to My Health Record, which contains a lot more summary information in that context. So we need to look at, and that's what we're doing through, in terms of the consultations we had, we put a report out in August of those consultations and the key themes. And one of the approaches that we're taking now is to work with existing partners who are doing things with primary care data to do proof of concept projects. And some of the things that we're looking at is, well, how do we demonstrate the benefits of this? What are the particular kinds of things that we can fill that need to be filled by these types of data sources as opposed to others that are on the horizon or extant as it stands?
It also, I think, with the My Health Record and the data set, information that comes through general practice, we mostly look at Medicare billing that's attached to a doctor. And so you don't necessarily get a really good picture of who the other health professionals are contributing to a patient's care. It's probably easier because there's an individual health professional identifier that you could skim through, look at My Health Records and go, well, actually the GP's uploaded, but there's also been a care episode by the physio, there's been a care episode by the practice nurse, and the patients wanted that information uploaded or updates done. So it might give you a better idea of the type of workforce that the patient's actually seeing, as opposed to who the patient's actually being billed by. And that might also be helpful later on for looking at types of service and types of health practitioners that will be delivering the care. And I can see that as a benefit.
I should note as well, if we're talking about My Health Record, that that part of those legislative changes that you referred to earlier
December,
were that the Australian Institute of Health and Welfare was announced as the custodian of that data for research and public health purposes. So we're in a good place to sort of manage the boundary between what the different data sources do. It's not an uncommon issue for us to have data sources that are very similar but have different purposes, and so we can manage that closely.
Adam, did you have a comment there? I can see you.
Yes, it's and I'll declare at this point that I don't have a My Health Record simply because I am waiting for the first crisis and going to make a judgment on how they recover. But I think it's actually important at this point for the data asset, whatever it is ultimately called, to be quite separate from my health record, because I think that makes the selling of it to the public somewhat more difficult. Because then you end up in the argument of, oh, we always knew there was a second tranche to my health record. So I think the data instrument, or whatever it's called, needs to stand in its own right and be quite a separate item.
That's an interesting point. I mean, I do have a My Health record, and I must admit, I don't have a chronic disease, so I probably, don't really use it that much. But when I have gone to an emergency department with a migraine, nobody was interested in it. But maybe next time it'll be different. And it's interesting too, that comment that you made. When I have a look at some of the records, and there's all these practitioners I've never heard of, because anytime you go for a test, that person who bills, their name gets there. So my GP is actually really important to me. I've been with her for 15 years, but she sort of almost isn't there. If you looked at it, look like all these other people who I don't even know from Adam are important to my care. So it's a really interesting thought. I think too, though, I personally would feel more comfortable with the connection with AIHW than I am with the current connection between My Health Record and Health Engine and Healthy, and I've forgotten the third name of that authorised app, because they are for-profit organisations that are already attached to My Health Record, and that I find much more disturbing than I would a connection with the Australian Institute for Health and Welfare, where it's data for good, really trying to inform what we're delivering and is it working. But I think it's an interesting point.
It's a milieu, isn't it, of consumer data and health data and the broader debates and concerns it raises. Can I just go to you again, Pip, and ask about how much involvement you think consumers and consumer reps should have, or what form that involvement should take in determining the data assets, operation and aims. We've had a consultation discovery phase of the conducted by the AIHW. These webinars are part of continuing that conversation. In terms of the next steps, data governance, really locking down the purpose and aims, what sort of involvement and what would good look like? What would success look like?
I mean, for me, of course, I'm always wanting to push us right up the end of the scale of engagement, right through to empowerment. But I recognise that sometimes these things can be difficult. But I would say from the very beginning, at all stages, at all levels, so that sort of concept of hopefully really being able to involve consumers at the highest level, almost having a co-consumer custodian concept, as it were, because I think this is our data, is what the community can think. I know that we talked earlier about, say, for example, the people that have registered for today and other people who have registered for other events around data, could they become our Australian Data and Privacy Panel, and that we could continue to work with a group of people. We really would need a lot of upskilling. I still feel I've been doing a fair bit more in this space over the last year because of work done in my state, but I still feel completely underconfident. It's hugely complex. You're always worried about, giving a consumer stamp to something that will turn out to be a hideous disaster. So I think the real opportunity, for me, good would look like at all stages, in all ways, lots of different forms, some surveys for people who are never going to come to the forums. Really interested to see what we could do around Aboriginal and Torres Strait Islander involvement. I think there's some great opportunities through the nacho sector and all that area, but it still needs to be pushed out further to community. So, obviously cultural and linguistically diverse. I'd really like to see that opportunity of co-design as much as possible. What can we do together? So we need time for that.
Yes, and perhaps I could, we've got about 2 minutes to go, so Michael, if we perhaps ask for you to make a concluding response to that. I know the report from the consultations available on your website talks about next steps and talks about the data governance and, and the overall governing arrangements you're going to be looking to put into place to steer this to its next stage. Has AIHW had any thoughts on how you're going to work with the consumer community to bring that consumer voice into that in a systemic way?
That's part of what we're doing today, is trying to hear some of those views about how that could be done, as we have also gone through the consultations that we went through earlier. We're keen to continue to have the conversation through the process. We are at the early stage, so we hope we're doing it from the start.
Ground floor.
And working through those issues. We will need to process, and we are thinking about some of the institutional arrangements. Obviously, it will need to fit within our existing institutional arrangements and consultation arrangements, such as our Primary Healthcare Advisory Committee. We are looking to form a steering group for this particular piece of work. That will be involved on a more detailed basis, and we will be looking for consumer representation on that group.
Please, not just one.
And we haven't settled how that's going to work yet. But working through that won't be the only tool through which there's consumer engagement. It's through a steering group, but through ongoing consultation and production of materials and information on our website and other channels to keep people informed and to get input from people through that as well.
Thank you. Well, look, I think that's about all we've got time for. So I'd like to thank our panel of experts for today's conversation. It was broad-ranging. I think we touched on issues other than consent, privacy and consumer protection, but I think that's okay. I mean, it really just does highlight, I think, the level of interest that data, and in this case primary healthcare data, where we do have gaps to fill through an asset like this, and I think I'd take your point, Adam. Asset is an interesting term, but data translates into information, which is an asset in terms of improving the system. So our next webinar is on the 11th of November. We'll be promoting that across CHF's networks and membership and social media, where we'll be doing a similar format, deep dive with a panel of experts, unpacking the benefits and the sort of aspiration, the future aspiration of this data asset and what it could deliver the system. So thank you very much to our panel and to the participants online.